Great, thank you. Bonjour tout le monde. Good to see everyone. There's more people on Zoom as well. It's an interesting phenomena we're going through. People shifting from Zoom meetings to in-person. It takes a while to come back to normalcy, but good to see some of you in the room. Welcome to the second meeting, second seminar of Perspectives in Youth Mental Health series. And we have Dr. Margaret Hahn. I have an introduction here I'm going to read out, but there's more than this introduction to talk about Maggie, and I'm not going to bore you with all of that. Taking the stage for Maggie to introduce Maggie to present her work. I'll give space in 5 minutes, or maybe 3 minutes, Maggie. So Dr. Margaret Hahn is a clinician scientist at the Center for Addictions and Mental Health in Toronto in the Schizophrenia division. Her research interests lie in translational work, focused on the complex interplay between schizophrenia spectrum disorder and cardiometabolic abnormalities. She currently leads several clinical trials examining novel intervention strategies for metabolic comorbidity. Her work also focuses on elucidating mechanisms underlying the intrinsic metabolic risk observed in first episode psychosis, and whether the disruptions in brain's bioenergetic pathways could explain the pre-morbid metabolic phenotype in a subset of individuals with schizophrenia spectrum disorders. She likewise oversees a basic science laboratory, which conducts cutting-edge research examining brain-mediated mechanisms underlying the high rates of obesity and diabetes in psychosis. From a clinical standpoint, Dr. Hahn is an actively engaged psychiatrist. She's translating research knowledge into patient care, including contribution to national clinical practice guidelines. At CAMED, she leads the Mental Health and Metabolic Clinic, one of the world's first clinics to simultaneously address mental and physical health. Her work has been recognized internationally and nationally, including through 2 recent visiting professorships to Denmark, where she's helping to build a metabolic clinic similar to the Toronto model. She was also the sole recipient of the 2022 CHR and CPA Glenda McQueen Memorial Award in recognition of top female leadership in academic psychiatry in Canada. Congratulations, Maggie, on that. There's many more laurels, but as I said, I'm going to leave the stage for Maggie to take over and tell you about metabolic disorders. Welcome, Maggie.
Oh, thank you so much for the introduction. And merci pour l'accueil ici. Trying out my French. Let's see if this works now. Okay, good. So very pleased to be here, and I'll be talking to you about schizophrenia spectrum disorders and treating the brain while minding the body. And I just have one disclosure. So I thought I'd take the next 45 minutes or so and review with you the associations between schizophrenia spectrum disorders, as well as other severe mental illnesses and high rates of metabolic comorbidity, including type 2 diabetes. And then we'll kind of take on a bit of a preclinical perspective and look at how antipsychotic medications contribute to metabolic risk, in particular through dysregulation of brain control of metabolism. And then I'll switch gears and talk to you about the clinical disparities that exist in physical and metabolic care in severe mental illness, and also discuss novel treatment opportunities. So by way of background, it's very well established that the leading cause of mortality across all severe mental illnesses with patients with schizophrenia disproportionately affected is cardiovascular disease, which shaves off 20 to 25 years of life. That's then in keeping with prevalence rates of cardiovascular risk factors such as metabolic syndrome, that's 2-fold higher in patients with schizophrenia spectrum disorders than the general population, and prevalence rates of type 2 diabetes, which are 3 to 6-fold higher. So very high increase in rates. When we think about how our patients get there to have these comorbidities, of course, it's not a straightforward phenomenon. So there's contributing effects of lifestyle factors, so poor dietary habits, high smoking rates, low activity levels, which occur for a variety of illness and social demographic kind of factors. There's these really fascinating intrinsic links as well that exist, again, premorbidly, in particular with schizophrenia and insulin resistance and type 2 diabetes. And then there's social health determinants, namely reduced access to medical care, which has to do also with this historical separation between psychiatry and other medical specialties. And then finally, adding fuel to the fire are treatments. So in fact, all psychotropic agents, with very few exceptions, carry metabolic risk. And antipsychotics are probably the best studied and also the worst culprits in terms of weight gain, insulin resistance, sometimes the development of frank type 2 diabetes and diabetic ketoacidosis, as well as dyslipidemia. But no matter how we end up with these comorbid severe mental illness and metabolic comorbidity, we know that this is associated with poorer outcomes. So you can imagine if someone goes on a treatment, gains a lot of weight, they may come off of it. And we see that very, very often in the metabolic clinic that I lead at CAMH. And then that often results in relapse, hospitalization. You can also imagine that having obesity and other metabolic comorbidities negatively impacts quality of life. We're also learning that there are links between insulin resistance and diabetes, which I think is a very novel and interesting field of research. As well, beyond obesity and type 2 diabetes being chronic severe medical conditions, we also now know that they negatively impact brain health. So for example, across non-psychiatrically ill populations, and also in schizophrenia, and recently we've also looked at mood disorders, there's an association between metabolic comorbidity, in particular, again, glucose dysregulation and worse cognition. And that's important because we know that cognitive deficits span all severe mental illnesses, and currently we don't have any effective treatments. So, excuse me. So this is an old slide. This was one of the seminal meta-analyses that was published when we became aware of metabolic side effects that really happened with the introduction of these so-called second-generation antipsychotics. And it just shows that these drugs aren't all created equally. And unfortunately, our two best antipsychotics, clozapine, arguably followed by olanzapine, cause the most weight gain. This is also an older slide, but I like to show it because it really shows differing trajectories in terms of when a treatment is started. So this was a study done in part in CAMH before my time there, but it looked at first episode psychosis individuals who had no or very little exposure to antipsychotics. And what you can see is in this young population, an agent like olanzapine causes about a 3 to 4-fold higher weight gain than what you see in this previous slide, which is, when you introduce these agents to chronically ill patients. As well, this slide exemplifies that an older agent like haloperidol, so first generation antipsychotic, historically never really thought to have metabolic liability. Not the case. Again, in this young population, you see a pretty significant weight gain. And this kind of weight gain trajectory of a drug like haloperidol parallels the weight gain trajectories that we see with these newer antipsychotics that were designed with the hope of being metabolically neutral. And that's not the case. So the ariprapizols, the newer agents, they all cause very significant weight gain, again, in antipsychotic naive individuals. Similarly, this was a large Danish population-based cohort study that looked at risk of diabetes in patients with psychosis before and after treatment with different antipsychotics. And what it found is, regardless of the class of antipsychotics, so whether it was first generation, second generation, and regardless of the agent, beyond the risk that was conferred of getting diabetes just by having a diagnosis of schizophrenia, which was 2-fold higher than the general population, all of these drugs, again, across agents and classes, further increase that risk 2 to 4-fold. So when we think about antipsychotics and how we arrive at insulin resistance and type 2 diabetes, there are two independent but certainly not mutually exclusive mechanisms by which this happens. So as I showed you, antipsychotics cause weight gain, and we know that increases in adiposity are a leading risk factor for insulin resistance. But beyond the weight gain story, we also know that these drugs can acutely and directly disrupt glucose metabolism. And how do we know that? Well, our group, as well as other groups, have shown that if you take a healthy rodent, all you need to give that rat or mouse is a single dose of these various antipsychotic agents, and you see very pronounced and acute impairments in insulin sensitivity and glucose homeostasis. And the good news is that this model has good translational value to humans, where similarly, if you take healthy volunteers and you give short-term dose administration with antipsychotics, you also see early disturbances in glucose metabolism before any shifts in fat distribution have occurred. So coming back to the brain, so we know that the brain is a key organ that regulates whole body metabolism. And this is a very simplified slide, but in fact, so what happens is these peripheral hormones like insulin, leptin, peripheral nutrient signals after we have a meal like glucose and lipids, they communicate to the brain what is happening in the periphery, and the brain then exerts effects and regulates peripheral metabolic homeostasis. And if the system is broken, then of course it places people at risk for obesity and other metabolic problems. So insulin, most of us know as a peripheral hormone from our undergraduate or studies in physiology, key peripheral hormone secreted by the pancreas, which regulates metabolism. However, we also know that the brain plays an important role in the action of insulin. So cross species, so across rodents, baboons, even chickens, dogs, and humans, if you give insulin into the brain or intranasally, you see reductions in food intake and sex-dependent changes in food preference. And you see, again, consistent cross-species suppression of production of sugar or glucose by the liver. And glucose production by the liver is the predominant source of hyperglycemia, for example, in diabetes. We're also learning that insulin in the brain has a role in cognition. So it enhances cognition, for example, in healthy individuals, with some signal as well in MCI and Alzheimer's states, and may also have an impact on aspects of motivation and perhaps psychopathology, which are of interest to us in the field of neuroscience and mental illness. And in keeping with this story, insulin receptors are not only expressed in the hypothalamus, which is a key region that is important for metabolism. They're widely expressed in the brain, where they have a role in cognition and synaptic plasticity. And moreover, what's really interesting is that key downstream molecules, signaling molecules from the insulin receptor, like AKT, GSK3 are candidate susceptibility genes in schizophrenia. And in fact, schizophrenia and diabetes genetic loci share commonalities. And that perhaps may explain, for example, why patients have this, now I think it's well established that patients with first episode psychosis have this intrinsic sort of glucose dysregulation that precedes even introduction of antipsychotic treatments. But as a starting point, we wanted to start the story by seeing what antipsychotics were doing to the system, and wondered whether antipsychotics could be disrupting insulin signaling in the brain, which might explain why, in part, they're causing some of these metabolic disruptions, and perhaps why they're not having a significant impact on, for example, cognitive deficits of the illness. So what we did is we started out in rodents. We used this very well-established model where we know if we infuse insulin into the third ventricle of a healthy rat, you see suppression of glucose production, and in male rats, you see suppression of food intake. And we asked as a starting point whether the antipsychotic olanzapine, and we started with olanzapine because of its frequent use in clinic and its high metabolic liability, whether in an acute dose paradigm to avoid adiposity, which can cause brain insulin resistance, again, whether acute dosing of olanzapine would block these seminal effects of central insulin to regulate peripheral metabolism. So to look at peripheral metabolism, we used a technique called the pancreatic euglycemic clamp. So this is a gold standard technique that measures whole body insulin sensitivity. And through a tracer infusion, we can also measure and calculate glucose production by the liver or glucose disappearance or disposal in peripheral tissues. And that's important because central insulin has this kind of target of inhibiting hepatic glucose production. What's also really important about this technique is it's conducted under so-called basal insulin levels. So what that means is we inhibit the animal's own ability to secrete insulin. And with a peripheral insulin infusion, we replace insulin at basal levels that don't engage the central nervous system, and we hold them there. That's why it's called like a clamp. And that then allows us to challenge the brain with insulin into the brain. So then we localize that insulin infusion and can isolate the effects, again, on the liver, where insulin in the brain suppresses glucose production. So this study, which was published back in 2017, what we demonstrated is, as expected, an insulin infusion suppressed hepatic glucose production. And lo and behold, when we co-treated the animals with a single dose of olanzapine, that effect was completely abolished, which supported the notion that at least olanzapine is acutely inhibiting insulin action in the brain. We then also looked at feeding. So rats are nocturnal creatures. And in the dark cycle, when you give them insulin infusions into the brain, you see suppression of cumulative food intake, which is what we found. And again, when we co-treated the animals with olanzapine, that effect was gone. So again, olanzapine acutely blocked the effects of insulin in the brain to suppress feeding. Interestingly, so we went on to look at leptin. This is work in progress. So leptin is also a really important hormone that regulates metabolism. It also suppresses feeding. And so when we treated rats acutely with leptin into the brain, we saw suppression of feeding in the dark cycle. But when we co-treated with olanzapine, unlike the effects on insulin, the effects of leptin to suppress feeding were left intact. So that may mean that olanzapine is actually acting acutely on leptin-independent pathways, which is perhaps good news for potential interventions. And why are we doing this work? Why do we care? So there were actually 3 studies while we were starting this work, 3 clinical RCTs that looked at intranasal insulin in patients with schizophrenia with the hopes that it could improve cognition and reverse or help with some of the metabolic dysregulation that's seen in patients, in part because of antipsychotic medications. And these studies were all very negative. And that could be for a variety of reasons, but one consideration is all of these patients were being treated with antipsychotic medications. And if indeed antipsychotics induce brain insulin resistance, we would not expect insulin to have any beneficial effects when administered to the intranasally. And in fact, what we may need to do is co-treat patients with insulin sensitizing strategies to glean these benefits of insulin. But before we go there, this is a study that's currently ongoing. We wanted to translate these findings from rats to humans to make sure that there's a good translational value. So essentially, we're doing the same project that we did in rats in humans. And so we're taking healthy volunteers, we're giving them intranasal insulin, which we know improves aspects of cognition, suppresses glucose production. We can also do pancreatic euglycemic clamps in humans, and the hypothesis is that short-term treatment with antipsychotics will abolish these effects of intranasal insulin, which will support the theory that in humans, also, these drugs are inducing central insulin resistance. Now, beyond hormones like insulin, leptin, nutrients are also critical in regulating metabolic homeostasis through the brain. So what happens is after we eat a meal, our glucose levels spike in the blood, and glucose can be transported through the blood-brain barrier in astrocytes through the GLUT transporters. And in astrocytes, it undergoes glycolysis to lactate. Lactate is a preferred fuel source for neuronal cells. So the hypothesis is that it's shuttled over to neuronal cells, and then it's further metabolized to generate ATP. And then ATP binds and activates the potassium ATP channels in the hypothalamus, which then signal through the vagus efferent nerve to the liver and suppress glucose production. So similar effects to insulin, but this effect can actually, of glucose sensing, can occur even independently of insulin, so in animals that don't have insulin. So as a follow-up, we then asked if antipsychotics would also similarly inhibit glucose sensing in the brain. And this time we looked at two antipsychotics, so olanzapine and haloperidol. Again, administered in an acute fashion to avoid weight gain and adiposity, which can also block glucose sensing. And we challenged the animals with a glucose infusion into the third ventricle at glucose levels that mimic what the brain sees postprandially, which we know, again, suppresses glucose production, asking whether acute treatment with these antipsychotics could block this effect. Sometimes I go through the pancreatic euglycemic clamp and how it works, but maybe I'll spare you that pain. I can tell you that I did these clamps as a PhD student and I had nightmares about them, so they're very challenging to do. But anyhow, just to say that we get three main outcome measures from the pancreatic euglycemic clamp. We get a measure of glucose infusion rate needed to maintain euglycemia, and that's a measure of whole body insulin sensitivity. We get a measure through the tracer analysis of hepatic glucose production and also glucose disappearance through the tracer analysis. So this was a study we just recently published. And so when we treated the animals with glucose infusion into the brain, approximating postprandial glucose levels, we saw, as expected, this measure of whole body insulin sensitivity was increased with the glucose infusion. However, when we co-treated the animals with olanzapine or haloperidol, that effect was gone. So this suggests that both antipsychotics were blocking glucose sensing in the brain, resulting in peripheral glucose dysmetabolism. Then we looked at suppression of hepatic glucose production, and as expected, a central glucose infusion in these rats suppressed hepatic glucose production. And when we co-treated the animals with olanzapine, that effect was lost, and it was diminished when we treated the animals with haloperidol, supporting that both of these antipsychotics are inhibiting glucose sensing, resulting in glucose dysregulation at the liver. When we looked at glucose utilization, we didn't see any effects of glucose. You don't expect that, and we didn't see any significant effects of treatments. So to summarize the study, we found that both antipsychotics, the second generation high metabolic liability, first generation lower metabolic liability, inhibit central glucose sensing, disrupting this key brain-liver axis and dysregulating glucose homeostasis. We went on to explore mechanisms. So we did RNA-seq bulk sequencing of hypothalamus. We also did this really cool technique called the kinome array through our collaborations in Toledo. We actually have these immobilized peptides on a chip, and these peptides are recognized by serine, threonine, or you can also look at tyrosine kinases. And then you load your tissue on, and you can see in real time which kinases are activated or deactivated by your different treatments. So much less labor intensive, I guess, for students than doing Western blots. And you get a lot of data using these omic approaches, but just to summarize in the slide, this was prepared by really talented project scientist in my lab, Dr. Sandra Pereira. So what we found in these omics approaches was that glucose stimulated, as would be expected, the potassium ATP channel in the hypothalamus. And again, the potassium ATP channel is both necessary and also sufficient to suppress glucose production. And lo and behold, these kinases, which were stimulated by CV glucose that activate potassium ATP activation, were blocked by both antipsychotics. And when we looked at pathway analyses from both of these techniques, it also implicated that the vascular endothelial growth factor is activated or stimulated by glucose, and it was inhibited by both antipsychotics. So summarizing this preclinical part, again, severe mental illness, schizophrenia spectrum disorders, high rates of metabolic comorbidity, including type 2 diabetes and insulin resistance. Pathophysiology is complicated. In addition to intrinsic lifestyle factors, we also know antipsychotics contribute through largely unknown mechanisms. Some of these are weight-gain dependent. However, there are also weight-gain independent or direct effects of these drugs on metabolism, mediated in part through the central nervous system, and it appears that antipsychotics may impair insulin and nutrient sensing. And of course, the goal of this work is to understand how antipsychotics induce metabolic side effects so we can hopefully develop targeted interventions. But beyond that, this is just what fascinates me, is the very same pathways I showed you in the hypothalamus that regulate peripheral metabolism, glucose metabolism. These same pathways are feed neuronal cells and are implicated in memory and cognition. So it may be that this whole system also offers insight to kind of this intersection between psychosis spectrum disorders and premorbid glucose dysregulation, and then perhaps a window also into mechanisms of how these antipsychotics work or don't work for different domains. Okay, so I promise I won't bore you with any more rat work. So we'll look at what's happening in the clinic. So before, just wanted to highlight a point. So illnesses like diabetes, dyslipidemia, hypertension, risk factors like smoking, medical illnesses like obesity, they are considered to be modifiable cardiovascular risk factors, which means that if they're screened for, caught, and treated, they can have a significant impact on health as well as life expectancy. So how well are we doing in individuals with psychosis to pick up these risk factors and treat them? Not so well, unfortunately. So this was exemplified in this 2014 study, which looked at prevalence rates of modifiable cardiovascular risk factors in first episode psychosis patients across 34 community centers in the States that were not research affiliated. And I just wanted to highlight the mean age of this cohort was 20 years old. So at 20 years old, you see rates of dyslipidemia that approach 60%, over half are smoking, and close to 20% already have pre-diabetes. They also looked at any sort of medication intervention. You can see in that light blue color, and it just wasn't happening. As a silver lining, though, I think our fields are starting to come together, and I'm an optimist, and I think we're beginning to see that physical, mental health, they're very interconnected, and you kind of can't separate one from the other. And what was very exciting was when the Canadian adult obesity practice guidelines were updated in 2020. For the first time, we had a chapter on comorbid obesity and mental illness, which I had a chance to contribute to. So I'll share with you what came out of that. But before I do, I just wanted to bring this slide up again. just highlighting that how individuals with severe mental illness arrive to have obesity and other metabolic problems is more complicated than the general population. And that includes these contributing effects of antipsychotic medications that, again, act on various aspects of metabolism through still largely unknown pathways. So that may also mean that interventions used in the general population to target obesity and other metabolic problems may potentially not work in the same way. And we also have to consider the fact that if someone has a mental illness and you're using a centrally acting medication, which is often the case with weight loss medications, you may glean improvements in psychopathology, or you may also consider that it may have adverse effects on mental status. So we have to look at that. Anyhow, coming back, so in the next slides, you'll see that because of these complexities of how obesity happens in severe mental illness, we have many off-indication medications that have been studied to target antipsychotic-induced weight gain. By off-indication, we mean non-regulatory body-approved medications that are looked at for antipsychotic-induced weight gain. Excuse me. But before we get into the what is happening in severe mental illness, I wanted to show you the slide of agents that are currently available and approved for chronic management of obesity. And so this is a really exciting field. So if I had given this talk 10 years ago, we would have had one approved agent, which is orlistat. Now we have 4 in Canada, a 5th in the US, with more coming onto the market. In Canada, we have orlistat, so that's an inhibitor of fat absorption in the gut. So you can imagine it can have some pretty unpleasant side effects. We have liraglutide. This is a daily injectable glucagon-like peptide 1 receptor agonist, and we'll come back to this class of medications. We have this combination medication of the antidepressant bupropion and the opioid antagonist naltrexone. Interesting, this is a psychiatric medication that's essentially approved for management of obesity. And then the newest kid on the block, and you may have heard different celebrities talking about this medication, is semaglutide. So this is weekly injectable GLP-1 receptor agonist. It's marketed in 2 formulations. So there's a formulation marketed for diabetes, which you may have heard about, Ozempic. And then there's a formulation that's marketed at a higher dose called Wegovy. And there are shortages of Wegovy, so we don't have that yet available in Canada. In the US, there's an additional FDA-approved agent that we don't have in Canada, which is a combination of the anti-epileptic topiramate and the sympathomimetic phentermine, and approved already for treatment of type 2 diabetes, hopefully very soon to have approval of chronic management of obesity, is a dual GIP, GLP-1 agonist, weekly injectable. And this medication is really exciting because it has weight loss efficacy similar to bariatric surgery. So fingers crossed, it almost seems to be too good to be true, but we'll see what happens. Moving into antipsychotic-induced weight gain. So we have been conducting a systematic review and meta-analysis of Cochrane that looks at any RCTs examining pharmacological interventions for weight gain in patients with schizophrenia spectrum disorders. So I just created this table which lists the different agents that have been studied in this context. And I bolded the ones that were better than placebo, and in brackets is the number of trials supporting or not supporting, I guess, their efficacy. And what you can see right away is there were 2 trials looking at orlistat. So this is Health Canada approved weight loss medication. They didn't have a significant effect to mitigate weight gain. And similarly, 2 trials looked at naltrexone bupropion and were not better than placebo, which possibly might again suggest that some of these medications may not specifically perhaps target the mechanisms by which antipsychotics, for example, induce weight gain. Sibutramine we won't talk about. That was pulled off the market because of cardiovascular concerns. Nizitidine is a histamine agonist, and while there were 3 trials supporting that it's better than placebo, they were of low quality, so not recommended. Aripiprazole, so this is an antipsychotic. As I mentioned, it causes significant weight gain in antipsychotic naive patients. So why is it here? So it was studied in the context to mitigate clozapine-induced weight gain, and it had modest weight loss effects, but study quality was poor. And one of the studies actually demonstrated that it was lean mass and not fat mass that was coming off. Then we have metformin. So metformin is the first-line treatment for type 2 diabetes, probably globally. So in this context, it's being examined off-label, so off-indication for antipsychotic-induced weight gain. So 11 studies supporting that metformin works. 3 studies supporting that topiramate has modest to moderate effects on weight gain mitigation. However, topiramate, the issue with topiramate, one, there's only 3 studies that looked at topiramate, but in epilepsy populations, it causes significant cognitive problems. So that's something I think that needs to be examined before recommending wide kind of scale use. And at the last time that we updated this Cochrane meta-analysis, which was February 2021, there were 4 RCTs supporting safety and efficacy of GLP-1 receptor agonists. There are now 6. And our center is currently conducting a semaglutide trial, RCT. So that will, I think, also be interesting to see, as semaglutide, it has greater weight loss potency than the most of the other GLP-1 receptor agonists. So this is just the forest plot of metformin. So you can see that across all the studies, there's a modest weight loss of about 3.5 kilograms. However, what's interesting is when we divided the studies by first episode psychosis or chronically ill individuals, we saw a 2-fold higher weight loss in first episode psychosis patients, so 5 kilograms. In the first episode psychosis populations, which might suggest that early intervention is more effective than once these abnormalities have set in. We also recently updated and published a Cochrane meta-analysis looking at prevention of antipsychotic-induced weight gain, so co-commencement with metformin when you start antipsychotics. And it also suggests that that works better than placebo, so about a 4 kilogram difference. Finishing off with GLP-1. So GLP-1 has many pleiotropic effects on metabolism. It's secreted at low levels from the gut cells in humans. It impacts appetite and weight through, again, peripheral and central mechanisms. In rodents, it has beneficial effects on cognition and synaptic plasticity, which I think is of interest to us in neuroscience. And there's one small study, open label, in bipolar disorder that also suggests that it may have cognitive benefits. So looking at the meta-analysis, again, this was when the 4 studies were published. You can see that there's a mean 4.7 kilogram weight loss. Notably, all of these studies use diabetes doses of the GLP-1 receptor agonists. So again, it will be interesting to see when studies are published that use anti-obesity doses. And one of the newer studies that is published and that isn't included in our meta-analysis did that, and they in fact saw potentially a greater weight loss of about 7 kilograms. So we will see. So what came in terms of recommendations from all this work while we were working on the guidelines? So it was very exciting because for the first time in North America, we have a recommendation for an off-label agent to mitigate antipsychotic-induced weight gain, which is metformin. And again, as I mentioned, topiramate, not yet recommended for routine use just because we need to examine some of its adverse effects a little bit better. What about on indication, so approved weight loss agents? So in 2020, when there were 4 studies, it was concluded that GLP-1 receptor agonists can be effective and well tolerated, but a recommendation was not made yet. This may change with the subsequent guidelines, and we'll also see what some of the other trials using obesity doses of these agents show. And again, there's not sufficient evidence at present to recommend orlistat or naltrexone bupropion. Naltrexone bupropion, though, I wouldn't sort of throw out of the picture because, for example, there was a small study with women with major depressive disorder and comorbid obesity where it seemed to be effective for both conditions. And perhaps it may have interesting uses for people with comorbid substance use disorders. What are the criteria for when we intervene? So just like the general population guidelines, we follow a BMI in the obese category or a BMI in the overweight category with at least one weight-related comorbidity. But beyond that, in terms of special considerations, we also recommend intervening if someone's rapidly gaining weight or rapidly increasing abdominal girth, or perhaps if they went off an antipsychotic because of weight gain and are restarting. So you can also use kind of a historical aspect to intervene. And we also intervene particularly with metformin, regardless of if someone's gained weight or not, if someone shows early signs of glucose dysregulation. Based on the guidelines and just sort of what we do in the metabolic clinic and a measurement-based care approach that we employ in the metabolic clinic, we came up with this kind of integrated care pathway or algorithm that we follow loosely. So we usually start with metformin and then kind of move because of its safety, and it's also cheap and accessible. And then we kind of moved down the line based on patient preference, drug coverage, and comorbidities. Just finishing off, so we talked about obesity and weight gain, but what about other key cardiovascular risk factors? What about type 2 diabetes? Well, not surprisingly, there is a great paucity of trials looking at interventions in people taking antipsychotics who have glucose dysregulation or type 2 diabetes. And similarly, all the huge diabetes intervention trials on which our guidelines are based systematically exclude individuals with severe mental illness. So again, we don't know if anti-diabetes treatments perhaps work in the same way or if people may need kind of more intensive treatments. So to begin to answer that question, we went into rats, pre-treated rats with metformin to see if it would work to prevent olanzapine-induced glucose dysregulation. And we found that it partially reversed antipsychotic-induced insulin resistance. So it reversed it at the liver, but not in fat and muscle tissue. And another group from BC, our colleagues from BC, showed a similar picture. So then we decided to take this story into humans. And we recently published a double-blind RCT looking at 16 weeks of metformin or placebo in young individuals. So our inclusion criteria were that participants had to be younger than age of 40, who had a psychosis spectrum, severe mental illness, and already at this young age had pre-diabetes or type 2 diabetes. And our primary outcome were measures of insulin sensitivity and glycemic control. Again, this was a pilot study, small, so 22 people completed. There was a 2-to-1 randomization favoring metformin. And what we saw is when we looked at our primary outcomes, so insulin resistance measured through this fasting index called the HOMI-R, we saw a very nice separation at week 16 favoring metformin. Interestingly, HOMI-R captures liver insulin resistance, so kind of similar to rats, what we see in rats. We looked at fasting glucose, and again, at 16 weeks, we saw a nice separation favoring metformin. And again, fasting glucose levels are representative of what is happening through the liver mostly. So when we looked at insulin sensitivity calculated from the oral glucose tolerance test, it's called a Matsuda index. We actually didn't see a separation between metformin and placebo. And that's really interesting because this measure captures peripheral insulin resistance more than liver. So as a translational scientist who likes rats, that made me happy that we're seeing sort of a a similar story. So metformin reversing potentially glucose dysregulation kind of at the level of the liver in antipsychotic treated individuals, but not in the periphery. In secondary outcomes, what was also interesting is that we did not find an effect of metformin on weight parameters. So this is in contrast to all the RCTs I showed you in the forest plots, which were all conducted in normal glycemic individuals. So again, it may be that once these abnormalities have set in, our treatments may not be as efficacious. So it may, again, support early intervention. We probably weren't powered, in fact, we weren't powered to detect effects on cognition or hippocampal volumes, and we didn't see an effect. So to summarize, good news is that the glucose-lowering effects of metformin appear to occur independently of its weight loss properties, so that encourages use of metformin in individuals with glucose dysregulation, it kind of independently of the weight gain story or weight loss story. But also suggests perhaps that patients who develop dysglycemia and have severe mental illness may require combination strategies and earlier intervention strategies. Finishing off with dyslipidemia. So what's out there, we recently completed a systematic review and meta-analysis of all RCTs examining pharmacological interventions for dyslipidemia in antipsychotic treated patients. And to summarize, out of 48 RCTs, what was kind of mind-boggling to me, only 4 RCTs examined approved lipid-lowering agents, and only one of these looked at statins, which are life-saving medications in the general population. And interestingly, when we kind of subgroup the interventions, the lipid-lowering agents didn't reduce key lipid parameters. In fact, metformin probably had the best effects on triglycerides and lipids. So it may be, again, that our patients or certain individuals may need these earlier, more intensive combination strategies. And we see the same thing in post-acute coronary syndrome. So it was, for example, shown in a Danish cohort study that post-coronary acute syndrome, mortality was significantly different, I think 9-fold higher in patients with schizophrenia than the general population. When they controlled for stents, that didn't sort of negate that risk. It was only in patients with schizophrenia who received triple protective cardiovascular surgery that risk, declined of mortality, declined to the general population. So last slide, severe mental illness, I hope I've convinced you, is associated with high rates of metabolic comorbidity. Metabolic risk is accrued very early on. It comes back to shave that 20-25 years of life. There is a dearth lack of studies examining interventions outside of weight gain in arguably a population that's at the very highest risk for dying from cardiovascular disease. And then special considerations likely exist in individuals with SMI, possibly requiring earlier and more intensive treatment approaches. Having said that, though, we should at minimum follow current general guidelines in absence of specific guidelines in severe mental illness. So then I wanted to thank my lab, without whom this wouldn't be possible. So this is a picture of the lab taken post-COVID when we were able to get back together. I co-lead the lab with Dr. Mahavir Agrawal. So he was a postdoc fellow in my lab, and now we share and co-lead the metabolic clinic. And now our group, it's quite exciting, has grown to close to 30 people. So it's growing. And I also like to thank my collaborators. And I think one of the funnest part of science, which can often be tiring and hard work, is collaborations, and then that often turn into friendships. So with that, I will stop and see if there's comments or questions.
Thank you very much, Maggie. It was excellent. It was a tour de force from rats to clinic. It was fantastic. I thought the rat picture was always Simpson's Brian for some reason.
It was, yeah.
I have a lot of questions, but before I go, I will see if the audience have hands. Yes. Hi, Mercy.
Thank you very much for the talk. It was very interesting. I was wondering if you noticed in all the trial that you examined, if there were any difference in the symptoms of the patients, depending on the group, or even in
in the trials?
Yes, in the trials.
So our metformin trial, we didn't see anything. We didn't see any signals. One of the GLP-1 studies looked at cognition. They didn't see an effect in cognition, but that was the study that didn't see any effects on metabolism. So there's one negative study where it was probably underdosed. But yeah, in general, again, there really haven't been sort of well-designed studies that look necessarily at metabolic interventions and symptomology. But in the trials that I showed you in the forest plot, those studies generally kind of don't look at psychopathology. There is some work done in PPAR gamma agonists that shows some small signals. I believe it was, I hope I'm not making this up. I think it was negative symptoms, but I have to check back. But yeah, this is work that's largely not explored well enough. But
use it anyway because Zoom is there.
I mean, great talk. Let's see here. So I was wondering, are there, selfishly, are there brain imaging signatures of obesity in these individuals who are on antipsychotics that track with what you'd see in regular obesity, and how much is it compounded by psychosis, and then how much of that gets reversed under these?
Reversal, we don't know, but yes, there's brain structural changes that look like diabetes. So Thomas Hayek has published quite wide several studies on that topic. So there are these signatures, but no one's really looked at whether treating these abnormalities can result in reversal.
Thank you. It was a great talk. 2 questions sort of related, more on the intervention side. One, has there been any work looking at what patient preferences and patient perspectives are regarding interventions? And the second, you said that even the things that are available, there's huge implementation gaps. Any sort of your own reflections and research on why there may be these implementation gaps and what we can do to address them?
Yeah, so we need to work together because these are things that, again, haven't been, I think, well examined in the literature. There was a study published out of Toronto where they did a qualitative sort of interviews of individuals who were referred to a general obesity outpatient clinic. And what came from these themes is that they didn't understand my, mental health issues. I didn't feel supported. I felt stigmatized in this clinic, and so that made us happy selfishly because I think it supports this integrated care where you simultaneously are treating mental and physical health disorders. And implementation, I don't know where to start. So I think it's a challenge, not just, for these interventions, but in general. So any suggestions would be welcome. Love to chat afterwards.
Well, I have one. Well, I have many questions, but I'll just ask one, which was very striking, Maggie. You showed that there is a very clear relationship between olanzapine and insulin-related mechanisms, insulin resistance, inducing insulin resistance. Is your thinking going in the direction that we should use metrics such as the HOMA index, for example, for predicting and selecting patients for whom we should be careful? We're using fasting glucose at the moment. We're using random glucose most of the time, and don't do much about weight gain prediction in the clinic. what's the thinking on prediction and prevention?
Yeah, I think we don't have good predictors for weight gain. Probably the best predictor is early rapid weight gain. So if you remember that slide with the olanzapine and haloperidol, it's really steep at the beginning. So you can pick out the individuals who are going to experience the most weight gain if you follow them closely for the first 2 weeks. And my own theory is those are the individuals you sort of intervene in. And then there's more controversial risk factors like lower BMI, and then well established, of course, being naive to antipsychotics, but probably rapid early weight gain is the best predictor. But it would be really interesting actually to see if something like simple like HOMA-IR can predict.
I'm relating that to the point that you showed in the last slide. Statins do not work as well in schizophrenia population compared to the general public. And I wonder if that is due to the delay in introducing it. I mean, we talk about lipid and other abnormalities after psychosis, after antipsychotics, but there's a progression toward disease over a period of time beforehand. Should we be looking for these things in child psychiatric clinics in the future?
Maybe yeah, maybe. But then, yeah, maybe. And often, the signature of antipsychotics is high triglycerides, low HDL. And if you speak to cardiologists, they won't treat that. They say that the studies show that lowering triglycerides, they're bad for you, but it doesn't help to lower them to lower cardiovascular risk. But those studies come from individuals in their 50s, 60s, and we're seeing patients who are 18, 17, sometimes younger, who have, very high triglycerides, low HDL. So do you intervene? Will the outcomes change? Like, again, there's these, I don't think you can extrapolate necessarily from the general population. Yeah.
I don't see any. Well, there's one more question, Massey. Go on.
A follow-up question. But as you said before, sometimes patients discontinue treatment because of metabolic effect, obesity. And is there any evidence that treating, for example, obesity improve adherence to treatment?
We don't know. So we're just doing a meta-analysis that's looking at weight gain and adherence. And clearly there's reductions in adherence with weight gain. But whether treating weight gain would increase adherence, we don't know yet. So my colleague, Mahavir, he did a retrospective chart review looking at clozapine and co-commencement of metformin with clozapine. And then he found weight reductions with metformin versus people who just were on clozapine. And he found that people who were on metformin were less likely to discontinue the clozapine. So you can't make causal links, but it's possible that because people were gaining less weight, so that's less side effects, that maybe it improves adherence. But yeah, great question.
Alban?
I'm not really well versed in the side effects of metformin or something like that, but I can imagine, would it be worth to try just to adjunctive treatment at the beginning and as a psychotic medication naive patient, so then you don't have any of these problems that people already having built up these resistances or these metabolic side effects? Yeah,
that's a question of debate. So if you speak with Mahavir, he will say, yes, start everyone on metformin. I think more cautious because metformin isn't without side effects. So people get gastrointestinal upset. When you're adding medications, people may be less likely to adhere. You can get low vitamin B12 levels that have to be checked. And so that's a side effect of metformin. So yeah, it's a safe, been around for 70 years, but do you intervene with everyone? Maybe you just have that discussion with people and see if they're interested. But on the other hand, if people get discharged from the hospital, they often get kind of lost and then they start gaining the weight. So yeah, I don't have an answer, but I think there's different considerations about that.
I'm a fan of metformin. I take it every day. It works for me. But I have a few reservations about other appetite suppressants in general, including semaglutide. they may not act, they may act differently, but in our population who are prone to depression, who are prone to a general reduction in appetite behaviors, like motivation reduction, is this going to be a problem for them if we consider them very similar to the general population where anti-obesity appetite suppressant work really well and they become glamorous with celebrity endorsements and all that? Should we think differently in terms of, mechanisms as well as behavioral methods in terms of intervening for our populations?
Yeah, maybe. But, arguably, for example, Cindy Kalkin from Dalhousie, she published a beautiful double-blind RCT where she took refractory depressive bipolar patients and with insulin resistance, and those who reversed insulin resistance on metformin had significant improvements in depressive symptoms, return to functioning. And she's found, this isn't published, I don't think she'll mind me saying, but anecdotally, like in that, regardless if you use semaglutide, if you use even a PPAR gamma agonist, you see these benefits in depressive symptoms. So I don't know, but I mean, yeah, so maybe, yeah, but we need to see. And anecdotally in our clinic, we've had quite a few patients on semaglutide, and they're so happy when they lose the weight. So they come back, and but I mean, we don't know the long-term effects, but yeah.
There's definitely a short-term antidepressant effect to weight reduction.
Yes.
Yeah, that's great. Well, it was an excellent session. Thank you very much, Maggie. It was a very important and impactful topic as well for youth with mental health problems. So please join me in thanking and congratulating Maggie for the talk. Thank you.
Thanks so much.